Our next speaker, I'd really like to say some nice things about him because I have lots of nice things to say. I had a very, very candid and vigorous conversation with a friend of mine, a very, very dear friend of mine who's also a psychiatrist. Don't get the impression that all my friends are psychiatrists. On the contrary, I only have a couple of them. But we had a very, 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 very heated conversation about which comes first, sleep or mood disorders. And I am of the opinion that you can't tell if somebody's got a mood disorder if they haven't slept in a reasonable fashion. So Atul and I were on a Zoom call several weeks ago, and I think he really gets it in terms of sleep and the role sleep plays in mood disorders. I hope I'm remembering that correctly, because if I'm wrong, I'm going to be really embarrassed. But anyway, really, I divide my world into two kinds of people: the people that get it and the people that don't. And as far as I'm concerned, he really gets it. So I'm really looking forward to him sharing his thoughts on management of insomnia.
Okay, well, thank you very much, Dr. Greenberg. And yeah, no, it's funny, especially with sleep and how it integrates with mood and anxiety. I'm at a bit of a unique position because I'm trained in both. I have a fellowship in sleep as well as mood and anxiety, and Roger has been a great influence in my life, and a supervisor as a student and as a fellow. So I'm very honored and happy to be here to kind of talk about sleep and how it integrates, with the theme of the day into this sort of syndemic of mood and sleep, because I see it both ways every day, in and out. And I don't know really how I would be a sleep specialist without being well trained in mood and anxiety. And unfortunately, that isn't always the common thinking. There are a lot of people who don't get it. And I also run a tertiary care mood clinic on Wednesdays, and I direct a sleep clinic in Edmonton, but consult all over the country. And did my fellowship, like I said, in Toronto, about the last time the Leafs won a playoff series. So, yeah, so basically, yeah, so we're going to kind of just do a quick whirlwind tour through the current thinking and sort of the management of insomnia as it definitely relates to sort of mood and anxiety disorders. My disclosures, again, very happy and honored to be here for this excellent sort of symposium, excellent talk so far. Thanks again to the sponsors and Abraxia and the CRTC for existing. We're trying to get these sort of initiatives in every province, because it's going to really, as we'll discuss after, probably has to be taken out of the hospital, unfortunately, as I consult to both our IV ketamine programs in Alberta and Edmonton, and there's been some struggles. So, we haven't mentioned that elephant in the room yet, and I think we've done a good job in a way, but there is this little thing called the pandemic, and it has kind of changed the world a little bit, and sleep is no different. So there is obviously the odd person that has actually done better, especially in the GTA, because they haven't had to commute for 2 hours every day. But as a rule, sleep has been disrupted. And I did not come up with this term. It was the National Sleep Foundation. Later bedtime, delayed sleep onset, reduced nighttime sleep duration, increased daytime napping. So that's just from a sleep point of view. Some of that is thought to be less signaling of circadian rhythm, more bad sleep behaviors, multiple sort of factors. Then there's ubiquitous anxiety, worry, depression, isolation. Homework boundaries are blurred. People are often doing a lot of Zoom meetings in their bed, which is not consistent with a good sleep, maybe on their phone a little more, having to be. A lot of people don't have a lot of room, especially if their kids have been home from school. And that throws things off as well, and that daily life disruption. And one thing I think we've neglected, and we're starting to see, as hopefully the pandemic wanes to some degree, is this backup of significant healthcare procedures. I see a lot of patients with chronic pain. They haven't been able to get their surgeries, they haven't been able to get their physio, and it all kind of comes out in their sleep. So I think a lot of us have felt this way during the pandemic. My mind's like an internet browser. Tabs are open, 3 of them are frozen, no idea where the music is coming from. That could also be a good description of, cognitive dysfunction, ADHD, or even mixed features or bipolarity. So I think, and I think I really like this sort of paper because it talked about, using some data, what a mechanistic model of improving sleep, not necessarily in COVID-19, but overall. And it talked about creating sleep resilience. And it's really important to cognitively set the stage for people in their sleep. They have this maladaptive expectation that they're going to sleep perfectly. And the first thing I would say is like your meals aren't, everything you eat isn't perfect. So why would every night of your sleep be perfect? So there's this over attribution and selective magnification and numerous cognitive errors with sleep. And I think it's really important to explain to people that all we're trying to do is build resilience. You know, I had a patient today who was just she was on with her husband on a Zoom call, and the husband's like, yeah, I get up a couple times a night, I don't worry about it, go back to sleep. Where the wife also woke up a couple times and then would start ruminating, right? And that impaired her sleep and really started created a cognitive cascade of problems that were inconsistent with sleep. So basically, we want to keep them from ruminating. Obviously, you have to look at perceived stress, and then looking at the concept of sort of anxiety or even hyperarousal. So that's just so we want to build this sort of resilience. And a way to kind of put that, these are my two kids. They have given consent to have them their pictures shown in this, just in case you're wondering. It's almost like you want to create a guardrail so they don't go off the abyss and create a sort of chronic insomnia. And how do we do that? It's giving them behavioral strategies, and I see using the medication. Sleeping pills have been unfairly vilified, and we'll talk about that towards the end, of not doing everything, but creating sort of a guardrail so they don't go over the rock of chronic insomnia, and also treating key comorbidities. Like I said, and if you understand insomnia as a dysfunction of arousal, it makes more sense. And then you understand why there's all these comorbidities. You have a cognitive arousal, a physiological arousal, you have this tired but wired feeling. And that's not dissimilar from an anxiety disorder. That's not dissimilar from ADHD. All these things run together. And this is why it's very difficult, to be parsimonious about what you're treating. Sometimes these things have to be treated consistently. And, obviously I get in trouble at sleep meetings for saying this, but I really think insomnia might be a variant of an anxiety disorder, with the issue target issue being sleep. Like, for example, social phobia, the target symptom being scared of fear of embarrassment. So they're not that different, and this is why they run together. And doing sleep work for long enough, you see a lot of pure GAD and a lot of anxiety with mild depression that may never come to clinical attention unless you kind of separate the two concepts. So what are some measures? Again, sleep-wake diaries are useful. You need to know what's going on. I don't like doing them in perpetuity because then people focus on the diary and not their behavior. But they may identify patterns, useful targets for treatments. Unless you're doing cognitive therapy, don't do this for more than 2 to 4 weeks. There's been a big uptake in, phone actigraphy, Fitbit actigraphy. There's been some limited studies of how accurate they are. And they're not bad in terms of how much you slept. They're not great for staging. So they're very good at telling whether you slept or not, but they're not great in terms of, you had this much deep sleep and you had that. And they create all these, proprietary algorithms that don't make a lot of sense and aren't really validated. So that's kind of what I tell patients. Okay, yeah, you slept that much, usually. Obviously, medications can throw them off. Let's work with it. They can be like a de facto sleep diary, but long-term, they can reinforce patients' maladaptive cognitions about sleep. And when we're looking at sleep studies, depending on where you are in the world, your access may be limited or very good. For example, if you're in Southern Ontario, really not recommended for routine insomnia assessment unless you're ruling out sleep apnea or parasomnias, but they often can reinforce, especially in somebody who is depressed or had a history of depression or doesn't want to admit that they've had a mood disorder, that sleep isn't the primary issue, right? So I've got a lot of normal sleep studies, and then the patient has been far more accepting for the fact to either take antidepressant treatment, augment their mood, or look at their mood treatment a little bit differently. Now, I think Dr. McIntyre spoke quite clearly and succinctly about the need for better questionnaires that are short, patient rated, and do what they're supposed to do. The insomnia severity index is none of those. To be blunt, it's a good idea. It's a symptom dimension, so it can't be done in isolation. It really needs to be done with the common comorbidities, and there it can be useful. So I would do an insomnia severity index in cojoint with major comorbidities. You would have to do a depression scale. This rapid mood screener may be a good way to check for bipolarity, because I can tell you a lot of mood disorders patients do not sleep after, or sleep too much or oscillate in their sleep have an element of bipolarity. And it's almost a more reliable symptom than mood sometimes. So I think it's really important. It could be almost the fifth A. Dr. McIntyre talked about the four A's. I would say the fifth A would be ongoing or cycling insomnia. Attention deficit disorder shows up, sleep apnea, restless legs, circadian rhythm. So you cannot look at insomnia in isolation. Okay. So like I said, what's insomnia and what's a comorbidity? And patients will usually selectively report the insomnia. They may downplay the comorbidity. Numerous referrals that our clinic gets are, on citalopram of 30, not sleeping. I'm like, I already almost know what that is before even seeing the patient. And, be very sure that you've addressed all comorbidities. And then you find that the treatments for sleep often work much, much better. Right. So I think that's a first step here in any sort of insomnia assessment. What are the comorbidities? And statistically, this is a large-scale study in Switzerland of a family practice network. And it serves the point, because we see this too, your big four, because you can't do everything in one visit, for those family practitioners on the call. As Dr. Greenberg knows, you have 8 minutes to do something, maybe. And both my parents are GPs, so if it can't be done in 8 minutes, they're not going to do it. So looking for the big four, especially at the first visit, would be depression, anxiety, chronic pain, and sleep apnea. And I would say there's a second tier nested in this depression concept, is what Dr. McIntyre mentioned about, bipolarity, mixed features. And this is second tier here, maybe ADHD, but I think the pain thing sometimes gets neglected as well. Pain and sleep are inconsistent neurological states. So looking at this, and this is kind of a layer cake analogy, some people are genetic who are sleepers. Then you have the circadian rhythm, which can be disrupted, the mood, anxiety, ADHD symptoms, pain, medical conditions, medications, an actual sleep disorder such as insomnia nested in the middle there, poor sleep behavior and stress. And you have to kind of parse out which one you're going to treat first and create some sort of treatment plan with the sleep, not simply just prescribing a sedative. Sometimes a sedative may be part of that, but I'll give you an example. Last patient I saw today, 57-year-old, night owl, working shifts, history of, bipolar 2 depression with mix, somewhere in between there, had a low-grade sort of sciatica, hypertension, snored, had some really horrific sleep behavior and stress. So there's a lot of different places to go, and there's no right or wrong answer what to start with. I would probably start with the comorbidities, but that's my bias. But they may not want to start there, but a plan needs to be instituted. So when you are treating the sleep, make sure you're not, sticking your finger in the fire hose of the comorbidity, I guess is the key point here. So moving on to treatment, again, like I said, make the diagnosis, review the comorbidities. There's no more primary and secondary. It's whether you have insomnia, meet the criteria, and what comorbidities come with it. So that's critical because that will influence your treatment algorithm. We hear a lot of, press and, rancor about, the use of quetiapine for sleep. If someone has GAD or a mood disorder, it can be perfectly reasonable, right? If somebody doesn't have a mood disorder or the mood disorder is stable, there are many other options I would use. So, so I think the comorbidities really is the number one thing that determines my treatment algorithm for which medications for sleep, or if I'm even going to use a medication for sleep. Then we have this well-known behavioral therapy, the hygiene, but which by itself, hygiene doesn't work except for only the mildest of cases. Really need some sleep consolidation or stimulus control, which basically, to put it in English, would be not laying awake in bed for long periods. So that's probably the most effective part of behavioral therapy. But the problem is this is over-focused on the B and not the C. Some people have extraordinarily maladaptive cognitions about their sleep, and if you don't address them, they're not going to do the behaviors. And I think the other point, a good scale for that, for those of you who are interested in this or want to assess that, is the dysfunctional beliefs and attitudes about sleep scale. It's a DBAS. It's a public download. There's a 16-item one, takes about 3-4 minutes and gives you real great insight about what they think about their sleep. And it can be a good starting point for looking at what cognitions you have to change, in some fashion, even if it's just a brief intervention before they'll do the behaviors. And that was obviously pharmacotherapy, but there's this feeling that these are mutually exclusive concepts, and they're not, right? They're not in depression, they're not in any of, central nervous system disorder. Why would they be in sleep? But the field has drifted into one way or another. And yes, cognitive behavior therapy is clearly first line. A lot of people won't do cognitive behavior therapy. If you look at the studies, only a third of people don't respond to cognitive therapy. It may not necessarily be enough. And you throw in the other 20% of people won't do it. And here you are left with about half of people that need some semblance of treatment. You wouldn't withhold an oral hypoglycemic from a diabetic just because they didn't follow the diet. So to me, I wouldn't withhold pharmacotherapy just simply because they weren't doing cognitive or couldn't do cognitive therapy. So some basic things, you're not going to do full CBT with these people, but some brief interventions have shown to be quite successful, even 1 or 2 sessions, and I think these are classic cognitive errors that we see in much of our disorders in mental health. It's expectations first, don't over attribute. There may be other reasons your life sucks besides insomnia, maybe the Leafs. I'm going to keep going at that until they win a series, but don't catastrophize after a poor night's sleep. Don't give too much importance to sleep, and develop some tolerance. These are classic cognitive errors that people who don't sleep seem to make consistently, and they have to be addressed at the beginning, not down the road. And even just talking about them can be a starting point. So moving on to treatment, and I think this is the rub. Sedation does not imbue alertness. And there's this sort of connection that, only if I slept, only if I slept, and then you try this sedative and that sedative and that sedative. If you have an increased alertness, you haven't really set them on the road to function. And if you're just getting 7 or 8 hours for accounting reasons, it's really not that useful. So it doesn't necessarily connect. And if deeper sleep does not lead to increased alertness, be very, very wary for comorbidity. So my running line is, okay, so I don't think it's a primary sleep issue because you've been on 5 different sleeping pills and none of them have worked. So what's really going on here? And that's often how we've uncovered a lot of mixed state or bipolarity at our clinic. And to do it earlier rather than later. Make sure any intervention, whatever it may be, it's increasing alertness and function overall. That is the end goal, not just hours of sleep. I frankly don't even care about hours of sleep. It's foundation. I'm asking, is your function improved during the day? So that de-emphasizes the sleep complaint that a lot of the chronic insomniacs have. Are you better? And you can start connecting that. And a great example of this is an anticholinergic, such as the over-the-counter doxylamine, Gravol, Benadryl. It will put you to sleep. It will compromise your cognitive function the next day, but you often have to make that connection for the patient. So the goal is to rise and shine at the same time, not like this guy. So when we're doing this, it's important to understand that the wake-sleep cycle is a balance, as many things are, between opposing neurotransmitter systems. Sleep is determined by the balance of sleep and wake-promoting systems. Sleep-promoting ones are GABAergic drugs, wake-promoting, orexin or hypocretin, which Dr. McIntyre mentioned earlier. There is a new dual orexin receptor antagonist, lemborexant, which actually blocks this, so it blocks wake. Other drugs have done this, but not as cleanly, such as antihistamines, antidepressants with antihistamines, and also things with effect on norepinephrine and serotonin, especially the 5-HT2A postsynaptic receptor, such as quetiapine, trazodone. These sorts of things can also be mild wake blockers as well. So understanding that is important. Are you using a sleep promoting agent or a wake blocking agent? And often, even though there's no data, clinically, we have to maybe use one from each class to promote sleep in somebody with especially a severe mood disorder or numerous comorbidities that requires some pharmacological treatment of their sleep. Sometimes you combine two. And we often see using a little bit of Zopiclone and some trazodone. And, maybe going forward, perhaps using, again, a Z drug, like the new one, Lunesta, or a dual orexin receptor antagonist, such as lemborexant, may work well together. But again, that's off label and there's no data. So be clear, are you promoting sleep or are you blocking wake? And if you're promoting sleep, options have not worked, perhaps you should change class. Now, this is not a well thought out concept, and there isn't a ton of evidence. There isn't a ton of evidence of, switching classes. We just all do it, right? So, just, to be sort of, it makes sense intuitively. So I would advise you to do that same thing with sleep. You don't want the teeter-totter pushed too far in one direction. You want a balance between the two, because this is, if you over push it in one direction, that's where you get sort of the side effects. So these are the indicated ones. This may vary in different countries, especially the US. The US has many more options for sleep in many different classes. But in Canada, we have 4 benzodiazepines that probably a lot of us don't really use because they're too long acting, not well known, or too short acting. But these are the ones that are actually indicated. Indication is a very political beast, as we all know. And a lot of us will use different benzos, but we'll just say the benzodiazepine class. One of the biggest mistakes in the sleep literature is lumping the Z drugs pharmacologically with benzodiazepines. It's a mistake made commonly, consistently, and it's really not particularly helpful. They're not as dissimilar as they were presented to be, but they're not the same either. They are non-benzodiazepines in terms of their chemical structure, but they're partial agonists at the GABA A receptor, is how they're best known. So they're partial benzo agonists. So they do many of the same things benzo do, but not all of them. And so the newest one is Lunesta, S-Zopiclone, sort of the S-isomer of Zopiclone. And we've had Zopiclone and Sublinox or Zolpidem in the sublingual form since 2011. Then the wake blockers, we have low-dose doxepin or Cyanor under 6 milligrams, which is a wake blocker, but it wasn't a particularly good one. And really the first true wake blocker, the orexin receptor antagonist, Dayvigo, which was launched towards the end of last year. So what's the difference? So again, and some of this is animal data, but it bears mentioning because it does dovetail clinically. You have the GABA A alpha subunits and various subunits, and they have their putative roles, such as hypnotic, anticonvulsants, which we see some benzos do, and the effects on memory, changing EEGs, sleep, learning and memory. And you can see the benzos just smack them all very hard. So they have all these effects, for good or for bad. Then you have Zopiclone, which is probably the most benzo-like of the Z drugs, which is why it's always a bit of a crossover. Once you get to 15 milligrams of Zopiclone, you probably lost the selectivity and are more or less giving a benzo to some degree. And the Zolpidem, which is very pure alpha-1, which really just kind of knocks you out, but can also affect your memory. Right. And here you have S-Zopiclone or Lunesta nested in between as sort of the most specific Z drug. And, the aspirational goal would be how escitalopram ended up being, superior to citalopram. Not sure if we'll get there with S-Zopiclone, but there are definitely some signals in that. Again, increasing your desired effect while minimizing adverse events. And just if you look at the summary of the data, S-Zopiclone, well, it's better studied, first of all. If we talk about sort of what evidence-based medicine is, many more trials than Zopiclone. The Americans have had it 15 years, and it's very poignant. The people that have moved here from America, many of them after 2016, were very frustrated to not have S-Zopiclone and found Zopiclone a very poor substitute. So again, that's just anecdotal data, but it does bear witnessing. And S-Zopiclone has a fair amount of data, including long-term use up to 1 year. And then here's the Erections. Like I said, the Erections, as Dr. McIntyre mentions, key regulator appetite, sleep, wake, many sort of basic hypothalamic functions. And there's 2 types, A and B. two receptor types, 1 and 2. And the competitive antagonists, they're quick on and quick off, so they don't hang around too long. Normalize sleep-wake function. Those of you from the US know Suvorexant, which was the first one released, and now Lemborexant is available in the US, Canada, and I think in Japan soon. And basically normalizing sleep-wake function with a different button. We are pushing a different button in the sleep system to perhaps target a different phenotype of insomnia. So this isn't going to be a panacea, but it will target an area we simply have not been able to target previously, and help either with a traditional sleeping medication or by itself a whole group of patients that were simply not well served by the sleep promoting drugs or the crudely wake blocking drugs that were available so far. And of course, that's limited, common off-label use, other benzodiazepines. There isn't a ton of evidence for sedating antidepressants. I think we all use trazodone. Trazodone is probably better repairing sleep than promoting sleep. And this is why we've always combined it with older antidepressants that would disrupt sleep. But the actual, I think it can be useful, especially for sleep maintenance, but the data isn't great, and its fall risk is similar to a Z drug. So, it won't hit your memory, but it definitely can, it's not as safe in the elderly as once purported. And tricyclics, again, only if I'm treating comorbidity, or only if I'm trying to repair sleep that they're on another agent that I can't avoid using. And that would be sort of a shout out to me of the newer antidepressants, because they definitely seem to have less disruption in sleep. Vortioxetine has almost no signal for sleep disruption. Neither does levomelanzapine, and vilazodone has a mild one, right? So that is definitely one advantage that some of the newer antidepressants imbue, and is less disruption of sleep. Obviously, with the quetiapine, and we talked about this, and this was made very clearly to me one day when I was on the Choosing Wisely group for Alberta, and there was all this hubbub about quetiapine for sleep and this and that. So they looked at the data, and there was a lot of use, but no one ever cross-referenced it by diagnosis of a mood and anxiety disorder. And once that was done, the use of quetiapine was almost nil. If quetiapine is helping your patients sleep, they probably have at least GAD. And there's data showing that 50 of quetiapine in the XR formulation, but nonetheless 50, is almost equivalent to an antidepressant. And then anticonvulsants can maintain sleep, especially in pain and restless legs, gabapentin and pregabalin, and there's many others that we can take in the question period. But again, I think, there's no evidence on this, but it's not very useful to use two from the same class. If you're going to combine, maybe combine from different pots. And again, always keep in mind, what's that medication doing? There's direct effect in sleep, but really treat the chicken. Again, it's a chicken and the egg, but treat the main issue. So this would be the engine on the car, right? The wheels could be the sleep. And for some people, it's the other way around. But if they're not responding to sleep medication, look at the comorbidity. Natural agents, L-tryptophan, not a lot of data, can have some theoretical usage. Take it with a carbohydrate, not with protein. There's kind of pushed very heavily by certain sleep specialists, but there really isn't a ton of data, but it is fairly safe. Seems to work specifically better in children. Melatonin is a great way to start fights at sleep meetings. Understand, that it has a chronobiotic effect 3 to 4 hours before bed, and a modest hypnotic effect. So it can work, but it's often a timing issue. It's a hormone. It's a terrible agonist of its own receptor. And we don't have the melatonin receptor agonists like they do in the US, which have been useful for some people. But I think the issue is, if there's a melatonergic dysfunction, such as in bipolar, mood disorders, ADHD, melatonin might move a little higher up the list for me. I've never gotten valerian to work in some small studies. And our friend cannabis, which is promoted heavily commercially for sleep, very limited data. Again, Health Canada says, and I would agree, very useful insomnia comorbid with conditions with cannabis evidence. So really, that's pain, right? Maybe resistant anxiety, but I'll only use it in a chronic pain insomnia, right? Or if everything else has failed. And you have to look at the cost benefit. And we really don't know a ton. Low doses of THC tend to promote sleep. We don't know what a low dose is. Higher doses can disrupt sleep. What that is very variable depending on the person and the preparation. CBD seems to help sleep mostly through the comorbidity, and it's not as psychoactively disrupting. So I'm a little looser on letting people use that. But again, they may simply be wasting their money. I think really the major area I'm looking at this is in chronic pain, because it's safer than perhaps using other stuff. Because I guess the other point is with cannabis, if I'm replacing something like an opioid, being opioid sparing or benzo sparing, maybe that's useful. And the OTC products, that's a no. And what a lot of colleges have not realized is the restrictions on sleeping meds have basically driven a lot of people to go to Pharmaprix or Shoppers or Rexall and grab some Tylenol PM and get delirious and break their hip and these sorts of things. So it's really important to kind of be aware of that and not be so rigid about prescribing low doses of sleeping pills on people who truly need them after sort of a proper evaluation. So it's not really necessarily like this. So I'll finish up with the off-label long-term usage. The monographs are very poor reflective in sleep. The 7-day, 10-day dispense with 30 days max, there's no evidence. That came from nowhere. That was a random bureaucratic decision. So it's a risk-benefit ratio. I would love to say our monographs are a bit more evidence-based, but they take the evidence they want. And I'm sure Dr. McIntyre, Dr. Rosenblatt know this intimately, right? Balance between the treatment of insomnia and producing next day cognitive impairment. And that's the driving issue. They all their cautions with driving, and I would start with that, but not sleeping can really make you a hazard on the road too. So it has to be balanced. And if you want to look at it, Lunesta, Esopiclone, Lemborexin, or Dayvigo have long-term data up to 1 year. So the evidence is there, right? And that's kind of what the American monographs say. Helpful to document that they didn't want to do the first line treatment. And you need to be vigilant whenever you're using a long-term hypnotic that something doesn't emerge. I've had lots of people, especially younger adolescents, that was an interesting question, that their bipolarity emerged through the pathway of not sleeping, and the long-term hypnotic was quickly replaced with a mild mood stabilizer, and that made them a lot better. Comorbidities can emerge, sleep apnea emergence, mood polarity issues, GAD to full-out depression. So don't throw the baby out with the bathwater. Referrals, when you're looking at sleep clinics in Ontario of a choice, ruling out other sleep disorders and sleep studies, understanding the interplay between the comorbidities, more intense CBT may improve with telehealth. All sleep clinics aren't created equal. Ensure clinic has someone to deal with insomnia, otherwise role may be simply ruling out sleep apnea. So summing up, again, we're looking at pro-sleep strategies, behavioral change, cognitive change, sleep without AM sedation, non-pharmacological strategies, treat sleep disorders and comorbidities, and then not over-sedating and blunting cognition. Thank you very much, and I will pass it back over to you, Roger.
That's wonderful. Just one quick question I think that probably is of interest to a lot of people here. What's your go-to for the elderly?
The go-to for the elderly probably would be, for me, I think you're looking at melatonin, maybe tryptophan. You can do short courses of Z drugs. There is data showing that they are pretty safe, especially Lunesta studies up to 24 weeks. But at long term, again, I would say, like I said, melatonin, tryptophan, looking at the comorbidity as well. And
elderly with dementia?
Yeah, again, melatonin, I think really organizing their area. Tryptophan, there is a good use. A lot of the Lemborexin studies were done in the elderly, so I think this could be an option, but it's still very early.
That's wonderful. Thank you so much for this.